Hi everyone. Thank you so much for joining the SIOP session, Childhood Cancer Services in Africa, Gaps, Inequalities and Solutions. My name is Noor Ranasinghe. I'm a parent of a survivor of childhood cancer. My daughter had leukemia when she was 3, was treated at 4 hospitals in London. Fortunately, she's made a full recovery and is currently at university studying physics and astronomy. I'd like to thank the London Global Cancer Week team for this session and Mark Lodge for soliciting an article about the SIOP Global Mapping Programme in cancer control. In this session, you're going to hear from highly respected clinicians and advocates from Africa, UK, US, presenting their work and collaborations. By profession, I'm a technical author working for the London Stock Exchange. But far more importantly, in my spare time, I'm involved with the International Society of Paediatric Oncology. This is SIOP. I'm also co-chair of the SIOP Global Health Education and Training Working Group, otherwise known as Cancer Point. We publicise training courses, conferences, webinars, fellowships, for clinicians treating children with cancer in low resource settings. I'm also a member of the SIOP Global Mapping Programme core team, which you're going to hear about shortly. And here is a picture of my daughter being treated at Great Ormond Street Hospital nearly 20 years ago. Through the SIOP Global Mapping Programme, we have documented that Africa has hospitals with state-of-the-art equipment, highly trained clinicians, and access to essential medicines. Unfortunately, this is not universal across the continent. Nevertheless, groundbreaking research is being done, and many effective global collaborations are in place. There is a long way to go to achieve universal access and ensure children with cancer are diagnosed and properly treated, and their families supported. There are many statistics about childhood cancer in Africa. However, statistics are just numbers and don't tell the whole story. As a parent of a child treated in the UK, I can never imagine asking about sharing a bed, access to chemotherapy or anaesthesia, nor if there were trained paediatric oncologists, surgeons, and medical devices such as radiology. We discovered gaps in these critical components in childhood cancer care, and we all need to do more to address this situation across Africa. This is what SIOP and members of the panel are currently doing. If, after hearing today's session, you want to get involved, then have a look at the SIOP Global Health Network website. There are working groups for multiple disciplines. SIOP welcomes passionate people like yourselves to advocate for universal health coverage and improved access to quality care, and to help reduce the shame, stigma, and myths of childhood cancer. SIOP really does need passionate people like you. It's a privilege to be part of this session, and I hope you all enjoy it. And finally, here's a picture of my family when we were on holiday in Edinburgh earlier this year. My elder daughter, the survivor, is on the right. I'm now going to hand over to Joyce Kambugu, paediatric oncologist from the Uganda Cancer Institute and Continental President for SIOP Africa. Thank you very much, and I really hope you enjoy this session.
Ladies and gentlemen, good morning, good afternoon, and good evening. My name is Dr. Joyce Balagade Kambugu. I am a pediatric oncologist at Uganda Cancer Institute in Kampala, Uganda. It is an honor to speak to you about pediatric oncology in Africa. And I would like to thank the organizers of this Congress or of this meeting for giving us an opportunity to speak to you all about this challenge. So childhood cancer is a global challenge. It was estimated that there were almost 400,000 new cases of childhood cancer in the year 2015, with 146,000 occurring on the African continent. However, only 57% were diagnosed globally, meaning that 172,000, 43% were undiagnosed. Substantial variation exists in diagnosis by region. For instance, in Europe, Western Europe, and North America, almost 97% of children with cancer are diagnosed. In Africa, this figure is much, much lower. For example, in Uganda, only 25% of children with cancer are diagnosed. And this situation is not much different from the rest of the continent. 80% of children with cancer in high-income countries can expect to be cured today with the current treatment modalities available. However, in low middle-income countries, where almost 90% of the global burden of childhood cancer is found, survival rates are as low as 30% or below. Yet, the causes for this disparity can be addressed. This is at the heart of the 2018 Global Initiative for Childhood Cancer and its target to achieve an overall survival of childhood cancer globally of 60% by the year 2030. The African context. 42.5% of the total population on the African continent are children under the age of 15 years. And while communicable diseases remain a significant cause of morbidity, over time, many countries have tackled this challenge, and there's been a gradual decline in infection-related mortality. Cancer is now emerging as a leading cause of mortality, threatening the achievement of the Sustainable Development Goals, the achievement of the WHO GICC target of 60% overall survival by the year 2030. Moreover, COVID-19 has taken Africa several steps back in the struggle to achieve these targets. Data on the burden of childhood cancer in Africa is imprecise and non-representative. What we do know is that the burden is high. The International Incidence Childhood Cancer 3 reports an incidence of 56.3 per million. However, this information was derived from 6 registries that met stringent criteria and covered only 5% of the children in the sub-Saharan Africa area. Therefore, this, in addition to the fact that there was no accounting for the children that were undiagnosed or unregistered, gives an imprecise figure of the burden. The Africa Cancer Registry Network, that reported on a broader number of registries, gave a range of incidents from 27.1 in Gambia to 308.2 per million in Malawi. This map that I got from the article published by Lancet in 2019 substantiates this matter. As you can see, more than 2/3 of the African continent are colored red, and red are the areas where there's no childhood cancer registration at all. Data on survival is even more scarce. We know that survival is low from our anecdotal observations and unpublished data, as low as 10% in some of the areas. The causes for this dismal survival are many, layered, and complex. A report that was given at the 33rd Conference of the African Union, that was a voice of the pediatric oncology community on the African continent, gave a summary of the causes of low childhood cancer survival on our continent, including failure to diagnose or misdiagnosis, delayed presentation or diagnosis, unaffordable or abandoned treatment, treatment-related deaths, drug shortages, lack of consistent adherence to treatment, use of reduced intensity treatment regimens to facilitate tolerability, because many of our children in Africa are malnourished or have comorbidities like tuberculosis, like HIV and others. However, this contributes to treatment failure and excess relapse. I thought that this situation is much like an anthill, and there's numerous anthills on the African continent. Anthills can be formidable, as tall as trees sometimes. But inside these anthills is an intricate network of interconnected channels, nooks and crannies. The situation underground is broader and even more complex. To me, this is akin to the situation on the African continent, where what you see above the ground is what I have just reported, these immediate factors that lead to a low childhood cancer survival. But underlying these factors, underneath the ground, are the more serious, more complex factors, including poor access to primary health care facilities, a low level of awareness among health workers and the population alike, broken referral pathways, non-existent or suboptimal human resources for childhood cancer care, comprehensive treatment for childhood cancer, including accurate diagnosis and staging, is lacking in many parts, poor healthcare financing. Underneath this level, what would correspond to the heart of the termite mound, where the mother termite or the mother ant lays her eggs, are issues like a limited knowledge about the problem of childhood cancer. We don't know its exact magnitude. We don't really know or understand how the factors that contribute to this survival are interrelated. What's their magnitude? Moreover, government prioritization of non-communicable diseases on our continent is rather low. A case in point being Uganda, where on top of only 8% of the national budget being spent on healthcare, a disproportionately low amount is spent on non-communicable diseases that contribute only 3.5% to the national health burden, disease burden. Now, not all termite mounds are equal. Some are more equal than others. All of the countries on the African continent have their own termite mounds. They have their own challenges that they face with regard to delivery of childhood cancer care. They have their own termite mounds, meaning that huge disparities exist across the continent. Some countries like Burundi have no cancer services at all for children, whereas other countries like Egypt, South Africa, have highly granular cancer treatment services. So what are these disparities? What is their magnitude? I conducted a brief internet search on how people get rid of their termite mounds. Some people use a shovel. Others pour hot water down the termite mound with liquid soap. There are others who use citric acid or vinegar, bicarbonate of soda, and other complex chemicals. But I rather like the picture in the middle that shows this community that's working together and hacking away at the massive termite mound with pickaxes or hoes or sticks, shovels, whatever they have at their disposal to attack the termite mound and level it. And this is what the Global Initiative on Childhood Cancer is calling us to do, to work together to address the massive termite mound that is childhood cancer on the African continent together. And so, SIOP International has led the way. It undertook the global mapping program to understand childhood cancer services, starting with Africa, to understand what all exists, what are the disparities, what is the magnitude of the disparities, And later on in this session, Dr. Gill is going to talk to us about the results of that study on the continent. We're also going to hear more about prioritizing childhood cancer in the global agenda. We will also hear from the voices of the nurses in pediatric oncology on our continent, and we shall know more about existing partnerships in this area. No child should die of cancer. Cure for more, care for all. I thank you for listening.
It now gives me great pleasure as the President of the International Society of Paediatric Oncology to introduce Her Excellency, Dr. Zainab Shinkafi-Bagudu, First Lady of Kebbi State, Nigeria, Founder and Chief Executive of the Medicaid Foundation, and Board Director of the Union for International Cancer Control, UICC. She's been a strong supporter of SIOP developing this session and is now going to give us a keynote lecture on prioritizing childhood cancer in the global cancer agenda. Thank you.
Hello, today I will be talking about how we can prioritize childhood cancers in the global cancer agenda. I would like to start by thanking the organizers of the London Global Cancer Week, as well as the International Society for Paediatric Oncology for inviting me to talk about this topic. The link between the Sustainable Development Goals and childhood cancers can be found in goals 1 to 5, whether we're talking about no poverty, reducing hunger, or gender health and equity. We can link these to the need to prioritize pediatric cancer. A diagnosis of cancer brings with it a lot of fear, uncertainty, and even poor knowledge on how to navigate. This is the situation that the 19.3 million cases that are diagnosed annually face, out of which 10.2 million die. The economic burden of cancer has been estimated to be in the region of $1.6 trillion US. And the burden of cancer, 70% of it lies in low middle income countries. This is the global picture. However, imagine a diagnosis of cancer in a child who is largely innocent, has not been exposed to many toxins either through lifestyle or from the environment, and thus is even more pitiful and worrisome. Yet globally, 400,000 new cases of pediatric cancers are diagnosed every year in children and young adults. Whilst this is relatively rare, agreed, compared to the incidence of cancer in adults, it is becoming a very important cause of mortality worldwide, because as we sort out the infections, particularly in the high-income countries, cancer is taking over. Pediatric cancers are characterized by being highly curable, and 50 to 60% of pediatric cancers consist of acute lymphoblastic leukemias, Burkitt's lymphoma, which is very common in malaria endemic areas like my country, Nigeria, Hodgkin's lymphoma, brain tumors, Wilms tumor, retinoblastoma, and other solid tumors. These represent 50 to 60% of pediatric cancers that is prevalent in all countries. So in 2021, where are we with pediatric cancers? The news is good. Survival rate for ALL has improved greatly due to the improved treatments that was introduced in the 60s and 70s. The 5-year survival rate was increased from 57% in 1975 to 92% in 2012. Similarly, for non-Hodgkin's lymphoma, the 5-year survival rate increased from 43% to 91% in 2012. Thus, in more recent years, brain cancers are the more predominant form of cancer deaths amongst children and has replaced the leukemias. Why do we need to prioritize childhood cancers? We need to prioritize childhood cancers because there is a high cure rate associated with this disease, between 80 to 90%, and thus it is potentially curable. If we improve awareness with some lifestyle changes, the outcomes will be better. Because diagnosis often happens late or not at all, if we prioritize the issue in our healthcare workers, we will get better outcomes. There is a poor representation of pediatric non-governmentals and civil society in global networks. Therefore, this leads to poor advocacy, particularly in low-middle-income countries where we have a very high disparity in outcomes compared to the high-income countries. Low-resource settings are often unable to access care, and this leads to financial hardships for families. And lastly, some children may face disproportionately long sufferings from long-term side effects and experience discrimination from treatment of cancer. Every day, more than 1,000 children are diagnosed with cancer. However, pediatric oncology represents one of the longest standing manifestations of global health inequities. Most children diagnosed with cancer live in low-middle-income countries where treatment is often unaffordable or even inaccessible. In high-income countries, 80% of children diagnosed with pediatric cancer survive, whereas in the low-middle-income countries, the prognosis is not as good. Only 20 to 30% will survive. If we take a look at the picture of pediatric cancer in low-middle-income countries, it's not a pleasant one. The health systems are weak. This has been further weakened by the COVID-19 pandemic in the last 2 years. Awareness is poor, as with most chronic diseases. There is no institutionalized screening system for even the cancers that we can pick up from screening, like retinoblastoma. Index of suspicion by physicians is on the low side. Most fevers are treated as malaria first before we look for other things. Access to diagnostic and treatment equipment is poor. And of course, the big elephant in the room, funding. With poor funding, we cannot have the right diagnostic equipment nor the treatments that we need. This is even more exacerbated by the paucity of health insurance and access to credit lines. This is the picture in low-middle-income countries. And the constraints faced by physicians and other workers in low-middle-income countries can also be well imagined. Infrastructure is poor, manpower is inadequately trained, there is a paucity of chemotherapeutic agents, diagnostic support as well is poor, health insurance is an issue. In Africa, there is only one population-based solely pediatric cancer registry, and this constitutes a problem for planning and providing care. The registries that do exist operate out of a tertiary hospital and so do not adequately quantify the incidence of childhood cancers. With unreliable data, we have unreliable care and even more poor management of our resources. The International Agency for Atomic Energy has done some research on what to expect from 2020 to 2050 in pediatric oncology. Globally, it is estimated that 13.7 million new cases of pediatric cancers will be diagnosed. 7.6 million will be diagnosed. However, 6.1 million of that number will remain undiagnosed. When it comes to the deaths, 1.8 million will occur in high-income countries, and the rest of the 9.3 million will be in low-middle-income countries. Therefore, there's a case to be made for investing, and they've also estimated that for each dollar invested, we can expect a return of $3. For these reasons and so many more, the World Health Organization launched Global Childhood Cancer Initiative in 2018. The aims are simple: to increase the survival rate to 60% and reduce suffering of all children living with cancer by 2030, as well as reduce the number of deaths by 1 million over the next decade. The strategy to achieve the goals has been laid out in a WHO Cure-All Action Plan that assesses the current situation of childhood cancer, provides good plan, cost, and finance, as well as how to implement a suitable program and, of course, monitor and evaluate that program. Our objectives for prioritizing childhood cancers should focus on the following: increasing the capacity of countries to provide quality services, increasing the prioritization at the national, regional, and global agenda, improving access to screening and diagnostic services, and it shouldn't be limited to paying out of pocket. Lastly, clinical training must, as a matter of urgency, prioritize non-communicable diseases. And how can we do these things? We can increase the availability and reduction of cost to chemotherapy for leukemias and lymphomas, which are the commonest cancers, increase the diagnostic capacities of primary healthcare centers and all centers for diagnosing pediatric cancers, capacity building for physicians and other healthcare workers. We can encourage civil societies to step up awareness and advocacy in their various countries, and also push for the inclusion of pediatric cancer in national insurance schemes. In my country, Nigeria, a cancer health fund was recently launched. However, it only caters to the 3 common cancers: breast, cervix, and prostate cancer. Similarly, a cancer chemotherapy access program exists in Nigeria, but there is no chemotherapy for childhood cancers included in the drug lists. Now, that is for the low middle income countries. Globally, how can we prioritize or increase the conversation about pediatric cancers? We must start to develop and maintain governance structures for shared objectives and results. We must support dialogue across sectors to strengthen the cancer care workforce and increase access to cancer medicine and technologies. Global bodies like the UICC have made laudable progress when it comes to increasing the pediatric cancer agenda. They have developed training manuals and translated it into so many different languages for use by healthcare workers. The UICC is a member of the WHO Global Initiative for Reducing Childhood Cancers, an active member. Also, the board of the UICC has a former president of the International Society for Paediatric Oncology, who is one of the active board members of the UICC. The cause of pediatric cancers can be included in the agenda there. However, we find that out of the 1,200 members, we have 300 or so engaged in pediatric cancers. We must encourage non-governmentals to do more and speak up, increasing advocacy, awareness, and interventions on pediatric cancers. We need to come up with public-private partnerships that will help us improve access to care and financing options for the equipment that we so dearly need to diagnose the diseases earlier. Perhaps it will also link pediatric oncology to topical global issues such as climate change. We might find that there's more resources that is channeled towards the disease. We need to advocate for including more children and young adults in clinical trials, and also include the issues that we have found, either good or bad, in the global initiative, in the World Health Assembly agenda that happens every year. We can also urge the global bodies like the International Society for Paediatric Oncology to create a special program for non-governmentals, particularly from the low middle income countries, where they're encouraged to carry out simple awareness programs at regular and specified intervals in return for some rebate in membership fees. In the capital city of Nigeria, Abuja, the University Teaching Hospital Babalada has received support from a non-governmental known as the Lions Club. They have built a fully equipped and furnished solely pediatric oncology unit. It is dedicated just to pediatric oncology. This is a laudable initiative, and we urge other global bodies to emulate from this and come to the low middle income countries and give back in such ways where the facilities are poor. Similarly, the Medicaid Cancer Foundation was recently at the University Teaching Hospital, Gwagwalada, to offer financial support to patients that are being treated for cancer. Some of these patients were pediatric patients. So what are our final thoughts? Indeed, the COVID-19 pandemic greatly reduced the opportunities that exist for increasing awareness and interventions in all cancers, but this was more profound in pediatric cancers. So there is a need to increase awareness and screening where it is possible. Telemedicine programs such as our One Call Away program, where patients and their families can receive support on the phone, are now more feasible and can be done across continents. Patients can be navigated to receive better care. We must urgently try to encourage our leaders to achieve universal health coverage. More political will is needed for that. My name is Dr. Zainab I am a pediatrician, the First Lady of Kebbi State, a board member of the Union for International Cancer Control, and for the last 13 years, founder CEO of the Medicaid Cancer Foundation, which is a foundation that works in Nigeria to educate, increase awareness, support treatment, and advocate for high-level policy changes in cancer control in the country. We have mainly focused on breast, cervical, and prostate cancers, which are the 3 common cancers in Nigeria. My vow today is to ensure that we actively include pediatric cancers on that list. What is your vow?
Good day, I'm Julia Chanlinor from the University of California, San Francisco in the US. I'm also the Secretary General of the International Society of Paediatric Oncology. I thank you for inviting me today to speak about a My Child Matters Nursing Award evaluation of project in Africa. Across Africa, there are 1.3 billion people, 8.7 nurses per 10,000 people in the continent, compared to 83.4 nurses per 10,000 people in the Americas. Over 5 years, the Sanofi Aspar Foundation has funded 37 nursing projects in low and middle income countries, 10 individual nurses in Africa, and 2 cooperative nursing projects that included African countries. The one award was for the cooperative group POEM, Pediatric Oncology in the East and Mediterranean, and included Algeria, Egypt, Morocco, Sudan, and Tunis. The second cooperative group was GAFOP, French African Pediatric Oncology Group, and included the countries listed and highlighted below. For the individual nursing awards, those are given to nurses in Burkina Faso, Ghana, Cameroon, Central African Republic, Uganda, Tanzania, Zimbabwe, and Zambia. Examples of the African projects, which received either €5,000 grants for 1 year or €10,000 grants for 2 years in education, research, or practice, are mentioned here. In Ghana, one was for training attachments in an advanced setting to impart specialist knowledge and skills in pediatric oncology for 2 nurses, was palliative care professional capacity building. Uganda, patient education for pediatric oncology, which focused on cancer awareness and/or advocacy, and improving referral rates for early diagnosis of childhood cancers in Northwest Cameroon by use of trained ambassadors and mobile money transfer, a project in education. 4 of the African projects were evaluated in 2020 to determine project impact. They included 2 projects in Tanzania and the Central African Republic, but also Indonesia, and El Salvador. Today, I speak only about the 2 African projects. Local professional qualitative researchers with experience in healthcare were contracted. The researcher, nurse awardee, and project partner in Tanzania determined who to interview. All interviews were conducted in local languages. Project had 6-week timeline. Consent obtained for evaluation from appropriate authorities, and the interview guide was supplied by the SIOP My Child Matters Nursing Task Force members who are nurse qualitative researchers. The same 2 SIOP nurses summarized the findings and prepared the final report. Tanzania stakeholders were interviewed in Kiswahili and English. 8 local facility nurses, 1 health authority, and 1 nurse colleague. District nurses mentioned advocating for children suspected of cancer with physicians in their hospital and expediting referral processes. Most nursing training is on process, not disease focused, like on cancer. And they, the nurse learners, felt they achieved and gained knowledge and skills. In the Central African Republic, stakeholders were interviewed in Sango, 13 parents, 3 nurse learners, and 2 hospital nurse supervisors. Nurse learners emphasized the value of practical training, quote, to touch the realities with our fingertips, end quote. They mentioned nursing care is more systematic now, and nurses have practical knowledge, for example, about chemotherapy complications and can perform pain assessments. The summarized findings included that project leaders had outstanding characteristics and/or skills, and their leadership was acknowledged locally in all projects. The role of local nursing association and/or NGO collaboration was key in all projects, and nurse learners increased pediatric oncology competence and confidence in nursing practice in Tanzania and Central African Republic. Parent empowerment and engagement in treatment process increased in El Salvador, and communication with nurses improved in Central African Republic. Improved health facilities, for example, referral process to pediatric oncology specialty care in Tanzania, and new specialty unit in Central African Republic. Bureaucratic and some operational challenges to initiating the award projects were mentioned. Stakeholder recommendation highlights included expand projects to more nurses and more regions, for example, additional trainings, increase practical training and less theoretical teaching, improve teaching materials, the quality and quantity of handouts, they wanted more and better, offer pre-service and continuing education in pediatric oncology, Central African Republic and Tanzania, and consider incorporating trainings in National Nursing Association programs was mentioned in Tanzania. Thank you for your attention.
Hello, everyone. My name is Jennifer Giel. I'm a pediatric oncologist at Charlotte Maxeke Johannesburg Academic Hospital in South Africa, and I'm going to be speaking on behalf of the SIOP Global Mapping Program. The International Paediatric Oncology Society, or SIOP, is now 53 years old. We're a multidisciplinary interprofessional group with strong representation from high-income countries, but really quite minimal representation from low and middle-income countries. What we know is that across our membership, there is a wide range of cancer survival rates. And we also know that the lowest survival rate is in Africa, which is why we chose Africa as the first continent to concentrate on. We know that most children in Africa with cancer go undiagnosed, and those who are diagnosed have significantly higher mortality rates than those in high-income countries. This image represents estimated incidence and mortality rates across the world. North America, for example, has an incidence rate of about 165 per million. Europe, about 139 per million, going right down to 75 per million in Asia. The red numbers represent mortality rates. And as you can see, Africa has the highest mortality rate. The unfortunate truth is that we actually don't have the data, just estimates of mortality or survival rates in African countries. So the objectives of the SIOP Global Mapping Program were that we wanted to survey as many global pediatric oncology professionals as possible. Obviously, quite an ambitious project. To start off, we wanted to create a baseline of pediatric oncology resources and services in Africa, because as I mentioned, that is the continent with the greatest need at the moment. In our survey, we wanted to take this baseline and use it as a springboard for improvement. And we're doing this to align with the World Health Organization, GICC, the Global Initiative for Childhood Cancer. The aim of that initiative is to raise the global survival rate to 60% or more. And from where I'm sitting, that is a really lofty goal, and we have to do everything we can to try and achieve that. The core team of this project consists of Eric Buffet, past president of SIOP, Scott Howard, immediate past Secretary General, Julia Chanlinor, the current SIOP Secretary General, and she's heavily involved in advocacy and global pediatric oncology nursing education, Lorna Renner, previous SIOP Africa president, who has revolutionized childhood cancer care in Ghana, Leila Hessison, immediate past president of SIOP Africa and current president of GFAOP, Alan Davidson, current advocacy chair in SIOP, Neil Ranasinghe, a technical author and parent of a survivor of ALL, and me. We based our survey questions on this article, published in 2017, considered a landmark article in the SIOP community. It represents a framework for developing adapted treatment regimens, which are basically all about trying to get clinicians in low and middle income countries to adapt chemotherapy and other management protocols to their specific locations. We know that when people use regimens that are too toxic for resource-constrained areas, that those children actually do worse. They have lower survival rates because of higher rates of treatment-related mortality and infections that cannot be treated with the available antimicrobial agents, for example. The article broke down every single component of childhood cancer care and assigned service levels, which go from level 0 to level 4. Level 0 represents a pilot project, while level 4 is really the best possible care that you can give. It's state-of-the-art, and it's got highly specialized services. There were 55 questions, which we translated into 3 main languages spoken by healthcare workers in Africa: English, French, and Portuguese. We launched it at the SIOP Annual Congress in Kyoto, Japan in November 2018. And then we had another launch at the SIOP Africa Congress in Cairo, March 2019. And we really did get a lot of responses, but because of our inclusive methodology, we got a lot of data that we couldn't really use. The Snowball methodology involved, it seemed like a great idea at the time. We were trying to be really inclusive, trying to get as much representation as possible and as much buy-in as possible. We created 280 social media posts. We sent more than 2,000 emails and WhatsApp messages, and we followed up frequently. And it felt like we were doing a brilliant job at the time. These images represent all the different ways that we tried to market the survey. We found, however, that there were considerable challenges with getting people to fill in surveys in Africa. We know that African pediatric oncology units are grossly understaffed. If you look at the graph on the right, this represents the number of physicians per 1,000 population. Europe has almost 3.5 per 1,000, whereas sub-Saharan Africa has about 0.1. We just don't have enough doctors for the population numbers, and we are asking that very stretched and strained cohort of physicians and other healthcare professionals to fill in a 55-question survey. We keep asking the same small number of people to fill in surveys. And obviously, there are language issues in a continent with over 2,000 languages, 10 times more than in Europe. We chose 3 main languages after speaking to quite a few colleagues around the continent. We piloted the survey to make sure that the questions were understandable, but the process could never be perfect. And we found that many keen people answered who actually didn't have enough experience or reach to be completely accurate. 48 out of the 54 countries in Africa were represented. There were 6 countries that no matter how hard we tried, we just couldn't get any answers from them. And this is most likely because there are no pediatric oncology services in those countries. 72% of the surveys were actually complete, and those were used for analysis. We split the data into themes, and those themes are currently being analyzed and written up by different interest groups. These interest groups include curative services, medical and nursing, palliative care, which encompasses various forms of supportive care, rehabilitation, radiology and nuclear medicine, collaborations and research, and social work and allied groups. We started by reporting on available curative services. One of the premises that we went into the study with was that countries classified by the World Bank as high-income countries or upper-middle-income countries would be more able to provide pediatric oncology care, or that various other economic and population measures might provide insight into the provision of care. And we found that this wasn't exactly so. It was actually a lot more complicated than that. The majority of countries reported that they had chemotherapy available continually, so that's encouraging. And most countries do actually have pediatric oncologists. That's also good, right? Well, not so good. As you can see, the availability of pediatric surgery is very patchy. On the right, in the green, that map represents the pediatric surgical services available. The dark green countries are those that have highly specialized pediatric surgery, such as transplant surgeons, tumor-trained neurosurgeons, etc. This ranges down to the yellow countries that only have general surgeons with limited pediatric expertise, and this results in many whole countries lacking the expertise to diagnose or treat these patients. If you think that 25% of pediatric cancers might be central nervous system tumors, and another 30% might be solid tumors of other sorts, and many patients require surgery to diagnose them, we have a problem. There are only 3 countries in the entire continent that are able to provide complete hematopathology services. These countries are Egypt, Kenya, and South Africa. And the reason these are important is because hematolymphoid malignancies make up a large proportion of our work, maybe 20 to 30%. These are the places that have absolutely no pediatric oncology services. There are 7 countries that have nothing. They have no pediatric surgery, they do not have any oncologists or anybody doing pediatric oncology, and they have no radiotherapy. These countries represent 33 million people. So in a continent of 1.3 billion people, is that important? Statistically, probably not, but quite devastating for the children in the countries involved. As one of the aims of this program was to improve services from the baseline, we delved deeper into why certain countries had certain services and why others didn't. We found that the availability of all 3 services correlated with income category, and low-income countries were significantly less likely to report provision of all 3 services. That makes sense, doesn't it? We also found that there's a strong correlation with radiotherapy, and we postulate that this is because it's really expensive to set up radiotherapy units, whereas surgeons don't need quite as much equipment, and we chemotherapy doctors really just need a room and a drip and a nurse and a pharmacist to get on with our work. Not as expensive as a lead-lined bunker costing millions of dollars. On the left, there's a typical population pyramid for Africa. We are very heavily weighted towards a young population, which also means that we have higher numbers of children with cancer. The bottom left is a typical European population pyramid, and you can see there are far more people in the young adults to middle age group. We found the population age correlated negatively with the provision of all 3 modalities. We found that a 1% increase in population less than 24 years decreased the probability of having all 3 modalities by 2%. Basically, the younger the population, the less likely you would be to be able to treat the childhood cancer that is more common in your country. The Gini coefficient is a measure of inequality within a country, with a coefficient of 100 representing a highly unequal population, whereas a Gini coefficient of closer to 1 reflects a much more equal population. The average Gini coefficient in Africa is 46, and my country, South Africa, has the highest numerical value for inequality, with Egypt having the lowest value. We found that the higher the Gini coefficient, the higher the spend on healthcare, but there was no association between the Gini coefficient and the provision of the treatment modalities required for childhood cancer. The gross domestic product seems like an obvious one, doesn't it? We found that if you had a 1% increase of gross domestic product spent on healthcare, this actually correlated with a 10% decreased probability of providing radiotherapy. So just because you spend more of your GDP on health, it doesn't mean that you're more likely to be able to provide radiotherapy. And also, a 6% decreased probability of providing all three modalities of curative childhood cancer care. This may be because a nation's increased spend on healthcare may go towards primary healthcare for more people before highly specialized expensive care for smaller numbers of children. The Human Development Index emphasizes that people and their capabilities, not economic growth alone, should be the ultimate criteria for assessing a country's development. Our findings showed that older populations had a higher HDI, not surprising. Thus, in sub-Saharan Africa, the population is younger and the HDI is lower. Countries with a higher HDI were more likely to have universal health coverage and to be able to provide all three services. We've learned a lot about the provision of the modalities of childhood cancer care in Africa, and we hope that the publications and data coming out of this program will be used to lobby for better services. We've also learned a lot about survey methodology and have changed our methodology to be more of an online registry, which can be updated by stakeholders in real time. I especially want to thank the many colleagues around the continent who answered the call to map their centers. Thank you to the SIOP community for being part of this effort to try and improve cancer services for children around the world. We're currently working with organizations in Latin America to map that part of the world, and Southeast Asia is also in the process of being mapped. And after that, we'll concentrate on the larger body of Asia. Thank you very much to the organizers for giving us this important platform. And thank you to the Sanofi Espoir Foundation, My Child Matters, for subsidizing a lot of this work. Thanks a lot. Goodbye.
I wish to thank the organizers of this symposium for giving me the opportunity to talk about the importance of pediatric oncology nursing in Africa at this very important global event. In 2020, the World Health Organization, together with the International Council of Nursing, released a landmark State of the World's Nursing Report. And this report presents a compelling case for considerable yet feasible investment in nursing education, including specialization, decent jobs for nurses, and inclusion of nurses in leadership. This report suggests that a stronger nursing workforce will contribute to improving health for all, strengthening the primary health care workforce on the journey towards universal health coverage, and overall contribute to sustainable development, including in spheres of gender equality and socioeconomic empowerment of populations. In 2018, the World Health Organization launched the Global Initiative for Childhood Cancer with the aim of 60% survival for children with cancer by 2030. This is a global target, which means Africa is not left out. In fact, the responsibility for achieving this target is arguably greater for Africa and other low and middle income settings, where survival rates are amongst the lowest in the world. The Cure All package was launched earlier this year, proposing the pathways to effective childhood cancer care. One of the factors in this pathway is the requirement for multidisciplinary teams, including supportive care and nutrition. Nurses are pivotal to the multidisciplinary pediatric oncology team. They spend the most time with the patients and families. The role of the nurse in the clinical multidisciplinary team has been in literature since the 90s. And we can summarize it in the following aspects. The nurse advocates for the patients, helping to empower them and trying to even out the power imbalance which exists in the patient-care provider relationship. The nurse protects the patient's dignity by making sure their privacy is respected and their information is treated with confidentiality. The nurse plays the role of navigating patients between different specialties and services and the different experts that form the multidisciplinary team. The nurse ensures that information flows between the patient and the multidisciplinary team in a clear and complete manner, and therefore ensuring effective communication. Organization of appointments, chasing results, medications, or even setting up meetings of the multidisciplinary team usually falls on the nurse. And finally, the nurse ensures transmission of care-related information onto colleagues in shifts for a seamless continuity of care around the clock. These roles in the multidisciplinary team can be extended to the context of research, community outreach, advocacy, guideline development, and policy. They would simply be inadequate without the critical contribution of nurses. The baseline standards for pediatric oncology nursing were published in 2020 by the SIOP Global Health Nursing Committee. These standards include staffing, which should be based on patient acuity, with a minimum ratio of 1 nurse to 5 patients. There should be formalized orientation with at least 2 weeks didactic and 1 month practical training. There should be continuing education with at least 10 hours every year. The nurse should be an integral member of the multidisciplinary team. There should be resources for safe care. And also there was a call for evidence-based practice with development of evidence for nursing practice for use in guidelines. In 2019, Morrissey and colleagues surveyed nurses around the world to see how much they meet the standards. The results from low-income countries and lower middle-income countries were eye-opening. Only 28% of nurses reported meeting the minimum staffing ratio of 1 nurse to 5 patients, and 33% worked in centers where nurses in pediatric oncology were rotated between other units of the hospital. Only 30% of nurses received formal orientation for more than 2 weeks, and 46% got at least 10 hours of continuous education annually. 41% of nurses reported being at meetings with patients at the time of diagnosis or relapse counseling. 63% of them were responsible for mixing chemotherapy at their unit. And low-income countries and lower middle-income countries were significantly less likely to have policies and procedures for nursing care. My colleagues and I have recently looked at the SIOP Global Mapping data for Africa, which Dr. Gill has talked about earlier. Only 9 nurses responded to this survey, unfortunately. Few centers had subspecialized pediatric oncology wards. Half of them had 5 or fewer nurses working at least 75% of the time in pediatric oncology. And 19% had specialist staffed pediatric intensive care units. Only 2/3 had a dietitian, 45% had a psychologist, while 28% had a child life specialist or play therapist. As was expressed in the baseline standard publication in 2015, nurses often fill these roles where they are absent. At the SIOP Africa Congress in Marrakech in 2017, we conducted a survey amongst 50 English-speaking and French-speaking nurses to know their strengths and weaknesses. And these were pediatric oncology nurses. The strengths reported included humanization of care, making sure that patients feel welcome in the hospital environment, pain assessment and control with use of validated assessment tools, skillfulness in explaining cancer care and treatment to patients and families, and upholding professional behavior in the discharge of duties. The first weakness described was the failure to re-evaluate nursing training, which was often provided by training partners or visiting experts. The second was weakness in knowledge and skills to conduct research and submit manuscripts for publication. And the third was poor documentation of nursing actions. At the SIOP Africa Congress in Cairo in 2019, we went further to investigate the research priorities for pediatric oncology nurses in Africa. 13 nurses participated in this survey. The most popular priority research themes were professional practice, psychosocial support, and education. The target groups for this research included nurses, children, parents, and health system. This year, we conducted a review of publicly available national cancer control plans to identify nursing contribution and inclusion of nursing-specific actions. For Africa, we found national cancer control plans for 21 countries. Nurses were involved in the development of 5 of these plans. We know this by checking the list of contributors, and in cases where their professions were not stated, we reached out to any contact we could find from the list. Moreover, there were specific recommendations for nurses documented in only 16 of these plans. There's obviously room for improvement in nursing engagement when it comes to cancer policy in Africa. Nonetheless, we have seen significant engagement of pediatric oncology nurses across Africa, notably in SIOP activities. There is the inclusion of the nurse representative in the executive board of SIOP Africa, and we have the Collaborative African Network for Childhood Cancer Care and Research, which includes nurses as one of its pillars for all activities and focuses on nurse capacity building and retention. The Francophone Africa Pediatric Oncology Group is carrying out nurse training initiatives in different parts of the continent. The Sub-Saharan African Nursing Network is developing a harmonized tiered curriculum for nurse training in pediatric oncology. The Global Hope Nursing Team from Texas Children's Hospital is carrying out nurse training activities in Southern and Eastern Africa with nurse leaders from Africa. The Sanofi Explore My Child Matters Award for Nurses has now sponsored over a dozen nurse-led clinical and community-based initiatives, including research for pediatric oncology nurses in Africa. We have seen significant engagement in working groups of the GICC focus countries, like the case of Zambia, where nursing-specific actions have been planned and some already implemented with nursing leadership. To conclude, the nurse specialists of the Global Initiative for Childhood Cancer, and this is an informal group, they published a commentary on the Lancet Oncology Commission, which was released last year. And this commentary was titled Strengthening the Global Nursing Workforce for Childhood Cancer. The commentary supported the overall call for workforce training and retention in pediatric oncology and highlighted the need for investment in nursing with prioritization of national and facility level subspecialized nursing education. Also called for recognition of pediatric oncology nursing as a subspecialty with non-rotation between units, adequate remuneration, and opportunities for career growth. And finally, he called for strengthening nurse leadership in childhood cancer services and the voice of nursing in decision-making. Adequate nursing engagement is essential to achieving the global goal of 60% survival by 2030. Thank you very much.
Good afternoon, good evening, everyone. Thank you very much, Katie and the team for inviting me. I'm pleased to present about the power of partnership. This presentation gave me also the opportunity to discover a very interesting book, which is exactly about the power of partnership. And this book emphasizes the need to differentiate between the partnership model in our own relationship and the domination model. The partnership model supports mutual, respectful and caring relation because there is no need to maintain rigid ranking of control. There is also no built-in needs for abuse or violence. Partnership relation free our innate capacity to feel joy, to play. They enable us to grow mentally, emotionally, and spiritually. This is true for individuals, families, and whole societies. So there are 7 relationships very important for every human being. Relationship with ourselves, with our loved ones, our co-workers, our community, our nation, our world, relationship with nature, relationship with the spirit. So what about pediatric oncology? And what can be the pediatric oncology model? So you can see that there has been lots of publications about collaborative efforts. And this publication from Carlos Rodriguez Galindo emphasized that the major challenge in pediatric oncology for the next few decades will be how to translate gains achieved in high-income cities to all children worldwide. Carefully designed initiative, development of national and regional frameworks for collaboration and incorporation for clinical, biomedical and health services research are crucial to meeting these challenges. So there is also lessons that have been learned from partnerships between high-income countries and LMICs. So you can see here in this publication from Raul Ribeiro that the initiation of pediatric oncology facilities in low-middle-income settings usually initiates with international agencies and international collaboration, but sustainability gets to be assured by local grassroots organizations and government agencies. And to achieve this goal of setting up pediatric oncology in such difficult setting, then you need, first of all, as you see in this table, you need leaders from both sides, from high-income country and leaders from low-middle-income country that are willing to devote time and efforts to the program. So to summarize, partnership is crucial if we want to develop pediatric oncology in every setting around the world. So what do we need if we want to develop fruitful partnerships? We need leaders and leaders from both sides, high income and low income country. We need sustainable collaborative programs, we need government engagement. So leadership is widely recognized to be a critical component of an effective health system. And we cannot have effective partnership if we don't have effective leadership. So a good leader can partnership with himself, his loved one, his co-workers, his community, his nation, the world, with nature and with the spirit. So there has been intervention to strengthen the leadership capacities of health professionals in sub-Saharan Africa. And more emphasis is needed on the long-term sustainability of leadership program in sub-Saharan Africa, which should ideally be financially viable with domestic resources and delivered by national and regional institutions and faculty. And also in pediatric oncology, the implementation of palliative care nurses leadership fellowship program in Uganda make us believe that confident, skilled, resilient cohort of nurses leaders will be able to contribute to national development of pediatric care in Uganda. So if you have African skilled leaders, then you can develop successful partnership like the Can Care Africa, which objective is to reach 60 to 70% survival rate for the most curable diseases, and in alignment with the GICC WHO objective for 2030. Same successful partnership for the Francophone African group, and those successful partnerships can lead to increased survival rate for common curable diseases such as nephroblastoma. We can have also successful South-South partnership, like the partnership between South Africa and Malawi. Good leader can also partnership with nature and have some success, like treating acute malnutrition in Wilms tumor using natural products like peanut butter. But not only those are the successes for partnership. There are a lot of examples and successful stories for partnership in Africa. But most important for us as Africans, we all believe in the Ubuntu principle. From the beginning of time, the divine principle of Ubuntu have guided African society. An authentic, individual human being is part of a larger and more significant relational, communal, societal, environmental, and spiritual world. We as Africans, we believe in Ubuntu, we believe in the power of partnership. Thank you very much.
So welcome back to the live session now. And thank you again to all our speakers. We're going to be recording the panel discussion, and I would like to ask Professor Lorna Renner, who's based in Ghana, to open the panel discussion with her experience about what she's achieved in Ghana and how this fits with what we've heard. So Lorna, over to you, and everyone else will switch their videos off whilst you're speaking.
Thank you very much for this privilege. Yes, I I think what's brought about the success in Ghana has been leadership, as many of your speakers have mentioned, strong local leadership, and obviously good partnership as well. We had a good twinning partnership, so we had some input with regards to improving childhood cancer care in Ghana. But with the leadership, we went up to the top. We involved the Ministry of Health, the Ghana Health Service, and we involved them right from the onset. And as a leader, one shouldn't just limit where you go to, aim for where they'll be able to make change politically. And what also helped recently was the Global Initiative for Childhood Cancer. And we got the political policymakers, Ministry of Health, to commit to improving childhood cancer care. And at every, and the other thing also is that together with World Child Cancer, we worked closely with the Ministry of Health and the educational authorities, the Ghana College of Physicians, to help improve training. So now we're training doctors to bridge the gap, capacity building. And also it's not only doctors, it's multidisciplinary. We're also training nurses and pharmacists as well. And together with that, we're also trying to improve pathology services as well as hematology services. But I think it's important you have a local champion, someone who is dedicated and willing to advocate at the highest level. And we shouldn't forget also, we also formed a parents group, and the parents group has also been key because they're also strong advocates, and with their voice, we got the people like the First Lady of Ghana involved in childhood cancer issues. And we actually, following on the GICC, we had a meeting in Ghana following on the GICC announcement. And with Ghana being one of the first countries to be focused on by WHO, the Ministry of Health was determined to be an example, a good example. So we went according to like what was mentioned earlier by the lady, Zainab, about the cure-all strategy, trying to build a center of excellence. And we did an assessment of our services, and then we went on to plan, and we've been able to also come up with a new national childhood cancer strategy for Ghana. Subsequent to that, we've been able to also form a Childhood Cancer Society of Ghana. And also we've been able to now, we're drawing up national treatment guidelines, but we're using the guidelines developed by SIOP PODC, as well as other guidelines to come up with that. So I think having a local champion is key, and then collaborating with external partners, but having local control as to what objectives and how you're going to approach and implement the processes. Yes, so I think it's local partnership, local leadership, involvement of government, and letting them see the benefits of investing in childhood cancer treatment. And with that, fortunately, the icing on the cake has been the announcement of childhood cancer services being covered under the National Health Insurance Scheme just this week by our First Lady, who is one of our ambassadors for childhood cancer. Thank you.
So thank you, Lorna. I'm now going to move to some of the questions in the chat. The first is from a fellow panelist, Her Excellency Dr. Zainab Shinkafi-Bagudu. Lorna, we thought you could take this one. Her question to us, really, as SIOP, is how can SIOP engage more doctors in Africa and vice versa? And not just specialists, but residents. So young people in training.
Yes, thank you very much. Actually, I think quite a number of the countries in Africa have pediatric societies. So we could, as SIOP, reach out to pediatric societies in the various countries and put our message across and try to get interest in SIOP from there. And then also we have various pediatric college, we have various medical colleges like we have the West African College of Physicians, the Ghana College of Physicians, the East African College. I think we should, as SIOP, reach out to them and maybe collaborate with them, let them know more about SIOP. And then I think aortic too is also a broad platform that we could use, because there, although aortic has mainly adult oncologists, but I'm sure quite a number of the adult oncologists also know of younger, well, residents and other pediatric colleagues that we could. So I think it's a matter of collaborating with these well-established societies in the various countries. And we should hopefully be able to get SIOP more visible and get more participation. Thank you.
Thank you, Lorna. I'm now going to move to a question that came in on the Q&A side from Hassan Malami Al-Kanji, and Alan Davidson has volunteered to take this one. And it's, in what ways are we preventing young women from being exposed to cancer predisposing infectious viruses, especially in our rural areas in Africa? And I guess that's not just about cervical cancer, but some of the other viruses associated with certain types of cancer, not always in childhood, of course. Alan, you volunteered to open the discussion on this.
Thank you, Madam President. I think there are other issues, but CA cervix looms very large. And it's a very fair question. I think, you know, the doctors of little people have for a long time, all of us, tried to carve out this niche for our patients. There's a recognition just today in a UICC meeting I attended about the fact that that 80-20 gap, the gap between high and low income countries, is one of the starkest gaps in oncology today across the world. And equally, whilst we want our adult cancer colleagues to recognize the importance of the work that we do, I think we are also reaching out, I know this is part of our plan, reaching out to work closely with them, both with aortic locally, or let's say regionally, and with the UICC. So in the here and now, that's a little bit, you know, it's a little bit down the track, but certainly one of the parts of the discussion that we need to have with our pediatric colleagues and with our cancer specialists across the continent is to say, you need to emphasize to your colleagues the importance of rolling out the HPV vaccine where you can, and advocating for access to the HPV vaccine. So that's a specific answer, Hassan, to your question. In terms of the broader remit, which is working together with our colleagues, you know, adolescent and young adult medicine is the space precisely where we are able to do that work, where kids who vaccinated today don't get CA cervix tomorrow, and young adolescents and young adults who have these shared diseases like Hodgkin lymphoma will be the subject of research and enterprise. So I encourage you to watch this space. I will say that I, as a pediatrician speaking in an aortic session on Sunday in this same London Global Cancer Week, I was very gratified at the reception we got, very generous reception from our adult colleagues. And equally, we will contribute, for example, to World Cancer Day on the 4th of February with a webinar that is going to kind of follow their hashtag, which is closing the gap. I mean, that's perfect. That's our problem precisely. So we will all work together. And in fact, Lila kind of knows that she's already in the frame to help us with more of that excellent work around partnerships. I think one of the things we want to flag up as advocates is that, and it's interesting how it resonated when I discussed it with the UICC today, is that we need to make sure that our partnerships are equal, and that low and middle income countries and the constituencies they represent have a stronger voice in partnerships across the globe. I hope that answers your question.
Thanks, Alan. Whilst you're waiting to unmute it, I'll just add a comment that was put in the chat really by a couple of other SIOP members. Michael Sullivan asked what might be the barriers in Africa for young doctors and nurses training in pediatric oncology. I mean, I could see an instant one from some of the figures that Jen showed us, you know, 10-fold less doctors per head of population. There must be many other competing areas of healthcare need. Okay, and I see that there was a question about the, is there a way of extending the time that student doctors stay in paediatric oncology services? In some countries, it's only 6 weeks. As Jen has put in the written answers, Jen, do you want to add a comment?
So, Kathy, just to answer that comment, WHO, SIOP, etc., that's a level a bit too high for making those kind of changes. They need to be made at individual university and hospital levels. So if the person who put the comment in the Q&A has a student organization at the university, that would be a very good place to start. And we would be very happy to support them in providing any literature that they need to support those requests. So okay. Maybe they can actually just email one of us directly.
Thanks, that's a really good point. And I think Courtney Sullivan, who's now the SIOP Nursing Network chair, had asked a question about encouraging more, greater use of advanced nursing roles, given the shortage of physicians, but also shortage of healthcare professionals in general. I don't know, Courtney, did you wish to expand on your question, or would Julia be able to answer this?
I'll answer while Courtney can connect. I think Glenn pointed out that one of the biggest issues we found is acceptance of pediatric oncology nurses as specialists, that it takes specialty care. And we've really been pushing hard on this. And I think you can see in individual countries the impact it's had when nurses like Glenn obtain their PhD, and there's others that I'm not going to remember off the top of my head. And I think as we see, and Glenn's involvement in the National Cancer Control Planning in Cameroon, as we see this leadership from nursing start to move forward, we can look to our colleagues in HIV, where certainly there's been task shifting, and there is a groundswell starting of conversation to exploit an advanced practice nursing role that makes sense in Africa. So let me turn it over to Glenn, because I see his hand up. He's going to be much more eloquent than I am. Glenn?
Thank you, Julia, and thank you, Courtney, for that very important question. I think that's a very important consideration to make for Africa. We have seen in places where nurse practitioners have been very impactful in filling in the gap for physicians in specialty care in pediatric oncology, even in rural settings in Africa. We have also seen where nurses have led in the delivery of palliative care. And this we also learn from HIV, the long history of nursing involvement in HIV care with the Uganda experience and the Africa Hospice group experience. So these are certainly things that need to be considered, but it needs to start with recognizing nurses as specialists in pediatric oncology and giving them a career pathway to stay in oncology and be more impactful.
Thank you. I think that both of you addressed what I was getting at perfectly. And, when we think about the training programs for physicians and drawing in specialists who are dedicated to the field, that's exactly what you were saying, Glenn and Julia, by creating that advanced nursing pathway, that specialist pathway, first for the bedside nurse, and then for the advanced practitioner who can treat and diagnose alongside supporting the medical team. It really is creating that capacity within the care environment for better quality care. So yes, thank you so much. And HIV is a beautiful example.
So if people want to stay on, there's two more interesting questions in the Q&A. The first is from Jabra Ganka, who's the president of Childhood Cancer International. And he said that CCI has not many member organisations in Africa, at least not as many as they would like to have, and particularly the French-speaking countries where they don't have any members. And if he's asking how can SIOP help CCI create those parent organisations, because I think we all believe it's very important. And maybe I could come back again to first Layla and then Lorna, a brief comment on that. How can healthcare professionals and SIOP as a society help locally in countries to develop vocal parent organisations that are involved in service improvement?
Thank you very much, Katie. SIOP is giving opportunity to organization to develop through empowering the pediatric oncology team, because without the parent association, the pediatric oncology team can progress. So SIOP can partnership with the CCI, so there can be partnership with the physician and the parent association, and try to make them create a parent association in each country where this is not existing. And we at the GFOP, we are to CCI Africa, and we should work on this, and GFOP can collaborate with SIOP and CCI so we can extend this to all the continent.
Thank you. And Lorna, did you want to add any comments from your experience in Ghana or your previous experience as the SIOP Africa president, encouraging the formation of parent organizations working with CCI?
No, I think Laila has said it all, but I think, you know, the parents' organization, sometimes we really need the clinicians who know the parents, because we really get to know the parents very well. And we know those that are really doers, outspoken people who can really come together and help form the society. Sometimes we need to get that going. You know, if we suggest to some parents and then we sort of start them off, and then would assist them with their meetings, and then they're able to take off after that. Once we're able to identify some parents who we think would be willing to form such a group and help with the advocacy, that would be from the local, you know, point of view. But I think SIOP should maybe bring this up, you know, because quite often SIOP, we just talk about our treatment, our management, you know, that sort of thing. But we don't really talk so much about the, it is there, but so much about harnessing the strength of the parents' associations, and that it's important for all clinicians to try to assist the parents group to be formed, and then they'll join CCI. I think we need to bring it a bit more in with our members, with our clinicians at SIOP. Thank you.
And then I'd really like to ask Neil to contribute, because he is a very persistent parent of a childhood cancer survivor who's really helped work in the UK. And I know how much energy you put into it. Neil, what are your thoughts for encouraging parent support groups and engagement with the healthcare professionals in Africa?
Thanks, Kathy. I think the key thing is just, as a parent, you want to be listened to. So it's really working together with the doctors, working together with the nurses, working with the researchers. And when we feel we're being listened to, then it's a great collaboration. And we've worked together really effectively in England. I can't see any difference why it'd be in other countries. So it's just listen to the parents, listen to what they're saying, and trying to get us involved.
Yes, thank you, Neil. Joe, I hope that's at least given you some thoughts about working, you know, reaching out to work with JFAOP, and also encouraging through SIOP, I think we should encourage all our healthcare professional members to have that open relationship with parents and survivors, because that partnership is absolutely crucial for effective advocacy and prioritization in local healthcare matters. Okay, I have put into the chat the link to everybody. Okay, we've put into the chat the link to the SIOP Africa Congress, which is taking place in March next year, between the 16th and 18th of March in Kampala, Uganda. Joyce is the chair of the local organising committee and SIOP Africa president. And we're very much hoping that this meeting will be able to go ahead with some in-person workshops wrapped around the Congress. And there's a lot of commitment to allowing healthcare professionals to come together to really discuss, and together with parents and survivors, how to take things forward. So please do go to the website, which is also there on the link if you're interested in being part of that next year. We're actually 12 minutes over time. I think we can wrap up there. I'm sorry, Ligua, that you weren't able to ask your question, but do send it to us by email. This webinar and the discussion that's followed has been recorded, and we will place it through the SIOP website, and I think also the London Global Cancer Week website, to allow people to offer it to other people who've missed it, or to revisit any of the talks they wish to see. I would just like to conclude really by thanking especially Neil Ranasinghe, whose idea it was that SIOP should have this session in the London Global Cancer Week, and to all our speakers, and particularly Her Excellency Dr. Zainab Shinkafi-Bagudu, because we've had just some fantastic talks and experience and inspiration, and I hope we can come together maybe in person at future meeting next year and in future years and see how much progress has been made. And of course, I've just seen a little comment from François Desbois. Of course, I should very much finish up by thanking the Sanofi Espoir Foundation for the My Child Matters program, which has really enabled a lot of the work to survey what's going on now in the African continent, and to allow many healthcare professionals to undertake short and projects to make improvements and set the future direction. So thank you very much, everybody. And I wish you all good evening, or getting on to the rest of your working day. And hopefully we'll see you in the SIOP Africa meeting in March next year. And I'm just realizing, getting lots of messages on my WhatsApp here that several colleagues in Africa are experiencing power cuts as we speak, which is one of the challenges that we don't often have to face here in London. Okay, and thank you again, Zainab, for your tremendous support.
Thank you, it's a pleasure, and I look forward to doing more with SIOP.
Excellent. We'll get childhood cancer up there in the global agenda. Thank you very much.
Nigeria, I'll talk to Lorna.
Yes, yes. Thank you.
Thank you. Bye-bye, everyone.
Goodbye, everybody.
Thank you very much.
Bye, everyone. Thanks.
It's a good